Hello, this is First Steps Towards an Enterprise FHIR Solution at the US CDC. And our presenter today is Ryan Harrison.
Good morning from the United States of America. I'm in Washington, D.C. And today I'm going to talk through the road mapping that goes behind building an enterprise FHIR solution at the Centers for Disease Control and Prevention, which is the National Public Health Agency of the United States of America. So the good news is that we're going to be talking roadmaps. The bad news is that we're not going to be talking about policy, regulations, data use agreements, implementation guide development, the ecosystem coordination that's required for the federal agencies such as the CDC, CMS, ONC, FDA, alphabet soup, or the coordination required amongst the ecosystem such as the FHIR accelerators like Helios for public health and Gravity for social determinants of health. So we're going to be focused on road mapping for FHIR servers. I'm Ryan. I'm a Presidential Innovation Fellow serving with the CDC, which means that I'm a industry specialist, background in architecture, working in FHIR since 2018, that has taken a sabbatical to do a tour of duty with the federal government. So I'm a federal employee for a tour of duty for a year or two, helping the CDC with a high-risk, high-impact project. And that high-impact, high-risk project is the modernization of the public health ecosystem under something called DMI, the Data Modernization Initiative. These are the 4 goals of the DMI as espoused by the Public Health Data Strategy. This is a document that's online right now. It was released in April, and it outlines the goals and objectives for public health modernization, public health data modernization over the next 2 years. So it serves as both a vision document and an accountability document for the modernization of the US public health ecosystem. Underpinning 3 of those 4 objective areas is the concept of data exchange. That is the exchange of information to and from the CDC. So one of the problems that was highlighted, but not new from the pandemic, was the difficulty of transporting and exchanging data across the public health ecosystem. So in July 2022, the CDC created a new system called Enterprise Data Exchange, tasked with implementing a concept called the CDC front door. This is the thought that there should be a conceptual front door for data going to and from the CDC to increase trust in the data flows coming to and from the CDC, to reduce burden on the exchange partners in the ecosystem with the CDC. So DEX, or Enterprise Data Exchange, is the implementation for the modernization of data exchange at the CDC, and I'm the architect for that system. I'm an architect, so I'd be remiss if I did not show you an architecture diagram. This is a conceptual architecture of DEX, the Enterprise Data Exchange. On the left, we have our data producers. On the right, we have our data consumers. And highlighted, we have the 3 conceptual aspects of DEX: transport, validation, and observability. Transport is sending data to and from the agency. Validation is asserting that the data that was sent is correct according to a specification or standard. And observability is the who sent what where problem. The CDC has diverse data producers and data consumers. You'll see an acronym on the slide, which is STILT, and that stands for state, tribal, local, or territorial. So when we say STILT, we're talking about public health agencies: state, tribal, local, and territorial public health agencies. Now, in the United States, we have a federal system of government. So the states are co-sovereign with the federal government. Tribes have tribal sovereignty, which is inherent to them. And then you have, Order 3000 locals and a number of territories. And all these diverse public health agencies, representing the STILTs, exchange data with the CDC. In addition, you have intermediaries, which are places where the STILTs send data, and then the intermediary sends the data onto the CDC. An example of this is going to be something like our report stream, which is an intermediary for sending COVID test data. On the very right of the diagram, you have data consumers. By and large, these are the national centers and programs within the national centers. The CDC is organized around disease areas. So you'll have national centers focused on infectious diseases. An example of that will be the National Center for Immunization and Respiratory Diseases. You have national centers focused around non-infectious diseases. National Center of Injury Prevention and Control is an example of that. And you'll have national centers grouped around thematic areas. The Global Health Center is an example of that. So you're talking about a very complicated exchange landscape between a bunch of different producers and a bunch of different consumers. So where are we now with respect to the enterprise FHIR implementation at the CDC? Last month in May, I'm proud to say that the Enterprise Data Exchange FHIR server participated in its first Connectathon. This is not the first Connectathon that the CDC has participated in, but it is the first time that the solution that will become the enterprise offering participated. We participated for a particular use case, which is the healthcare surveys use case. Briefly, you have a hospital system which has survey data. Based on events and various criteria, that system sends information to the CDC via messaging. That data is then put into a data lake and used by the program. And we demonstrated with test data, with a test EHR, the end-to-end flow for this exchange using a CDC FHIR server that will become the enterprise FHIR server, from the EHR to the sidecar, to the CDC, to a data lake, to a BI port, to a Power BI dashboard. That demonstrates the end-to-end flow. That's where we are today. Where this maps to the enterprise FHIR roadmap is phase 1. So phase 0, if you roll back the clock, not that long, about 6 months for the enterprise solution, we had an out-of-the-box Azure API for FHIR sitting in CDC's moderate environment with no authorization and no one using it. There are other efforts at the CDC around FHIR servers. And again, the CDC has participated in Connectathons before, but these were based in individual offices or individual divisions, not a solution that was designed to be shared by folks across the enterprise. In phase 1, we chose one use case with these attributes. And we did this for a few reasons. One was that the messaging paradigm is something that's very common at the CDC. So most of the data flows, not all the data flows, but most of the data flows to the CDC are reporting. So the messaging paradigm is very convenient for this. You have a sender, and that sender is going to be using process message, $ process message to send data to the CDC. This use case relies on a reference architecture called MedMorph that just received as 1.0 at ballot. So we had a reference architecture to implement to. That reference architecture is being used by healthcare surveys, but it's also being used by flu and cancer. So we had all the components for a very good first use case. We had a reference architecture, we had a specific content IG for healthcare surveys, and we had a queue of other programs that were planning to adopt this reference architecture with their own content IGs. Looking forward into phase 2, it would be nice to onboard a person-based use case. Person-based use cases are less common at the CDC, since most of the data that the CDC receives is de-identified. But from a solution standpoint, having a machine authentication scenario in phase 1 and a person authentication scenario in phase 2 would be very convenient. TBD on exactly what the second use case will be. And then for phase 3, which is some years in the future, we're looking at aligning the FHIR roadmap of the CDC with a portion of the FHIR roadmap from the prevailing ecosystem. So I'm not going to get into detail on what TEFCA is. It stands for the Trusted Exchange Framework and Common Agreement, but suffice to say it's the United States' latest iteration of trying to do networked exchange. That is, if I have a person show up in a hospital in California, how might they query the network to see where that person has been seen and get records on them? The first iteration of TEFCA, which is available starting now, is using CDA documents, and in the future, they plan to onboard FHIR. So for phase 3, we want to intersect these two roadmaps. When TEFCA FHIR adoption starts, we want to have use cases available for the CDC to use TEFCA for public health. All of those business phases are aligned with technical phases. So as a principle, we don't follow build it and they will come. We have plenty of use cases. We're going to select a use case and we're going to build out the capabilities of the FHIR server use case by use case, starting with this machine auth use case and process message for healthcare surveys, and then going on, if we get a person use case, these technical standards, and when TEFCA comes, those technical standards. And there's flexibility here. So for example, if phase 2 is not a person-based use case, but rather it's a machine auth use case that uses REST, we would move up the bulk IG into phase 2 to support the use case. So stepping out a little bit, we're gonna get a little bit more abstract now and think about the architectural principles underpinning this roadmap. We spoke about how the CDC has very diverse data sources, the STILTs, the state, tribal, local, and territorial public health agencies. The CDC also has diverse types of data coming to it. It's got case data, lab data, et cetera. So how can one provide an enterprise solution or enterprise suite of solutions around FHIR that reduce burden on thousands of senders and 100 or so disease-specific programs, while at the same time supporting 6 different core data sources with very different needs? Case data looks a lot different than vital statistics data, for example. And the way that I've conceptualized this as an architect, or the bet, is that we can decouple the content layer from the exchange layer or the exchange paradigm. So in building out the capability, we're going to intersect a specific use case, which comes from one of those content areas, with a specific transport paradigm. We're then going to mature the specific transport paradigm as a shared service from alpha, which is where we are now, to beta, to eventually general availability. And in doing so, the hope is the national centers can provide their technical expertise about the data they want. They can provide the implementation guide, the content implementation guide that specifies the data they want. And ideally, that content implementation guide is going to be inherited from US Core or the US Public Health Domain IG. But in theory, you can have that content IG and use that content IG with any of the exchange paradigms. As I mentioned earlier, where we are today is in testing by Connectathons with a messaging paradigm. This is a messaging based on triggers. For the next use case, I'm not entirely sure where it's going to come from, but my spidey sense tells me it's going to be a REST query, either individual resources or bulk access. And the advantage here is if you think about say a case, if you think about a scenario of sending data to the CDC, you can either do a push, which is the messaging scenario that we're doing with healthcare surveys, or you can do a query, which is where the CDC has a list of endpoints. It has explicit data authority to query those endpoints, and then you execute the query against the FHIR server of the public health agency or the system of the public health agency. And with that, I'll actually have more time for questions. So I'm curious what the audience has to say. Thank you.
I'll start with questions in the room. Anyone here have a question?
I've got a question. This is a great presentation. Thank you so much, Ryan. I don't believe I heard you mention subscriptions as you've been thinking about the different techniques or approaches to exchanging data. And I'm curious if you've explored that at all and if it's being considered in your transport paradigms there.
Gotcha. So yes, the short answer is subscriptions. In my view, well, they're implemented as REST queries, but they really fall under messaging. They're under messaging, and they're a part of the reference architecture that we're using. So I didn't unpack all the details of the reference architecture that we're using here. But the MedMorph reference architecture includes the use of subscriptions between the EHR and the sidecar. So if I'm gonna kind of mock this up in the air, you have an EHR, you have a sidecar that listens to the EHR. You have the CDC's FHIR server. The connection between the EHR and the sidecar is done via FHIR subscriptions as a part of the MedMorph reference architecture. So we've already included within the data flow, we've already included subscriptions. Does that make sense?
Yep. Any more questions in the room?
Yeah, hi. I was interested in your comments about looking for an individual level use case, and what comes to mind, of course, is notifiable conditions, where there's already a pretty clear pathway through ECR and CCDA based reporting, or other kinds of registry reporting, and there I'm starting to run out of ideas. But I'm curious.
Gotcha. Yeah.
Like,
so
beyond this, trauma registries, cancer registries, all that sort of stuff.
Yeah.
What other individual use cases might you look for?
So there's a distinction between the grain of the data being an individual, as is the case in the examples you mentioned, and the authentication and authorization being based on the individual. So if you take a case reporting flow, in the public health jargon, there's a distinction between case reporting and case notifications. So case reporting is between the locals and the states, and case notification is from the state to the CDC. So the data being transported is de-identified information about an individual, but the actual connection from the state's case surveillance system to the CDC is actually a machine-to-machine connection. So when I talk about phase 2 and like it would be nice to have a person-based use case, I was talking about a person-based authorization and authentication. And I don't actually know what the next use case is going to be. My spidey sense tells me it's going to be in the REST-based paradigm, either with individual REST request or bulk. But I know not where it's going to come from. We're actively working with our colleagues in the various national centers to select the next use case for pilot under the Enterprise Data Exchange.
Thanks. Yeah, I completely missed the point that you were talking not about individual level data, but about person level authentication to that data.
Correct.
So that is really interesting.
Yeah.
Does CDC have data that it releases back to individuals at this point? Like that kind of, is there a path, an existing use case that falls into that description? I know we have some of that at the state level, but
yeah. So the short answer is that most of the use cases, not all, but I'd say the vast majority of use cases that involve person auth are at the states. So if I'm a state, I'm going to have a immunization registry, and as a state, I might want to allow individuals to access that immunization registry. That's a person-based use case where the granted data is a person. It's a person-based use case where the authorization auth is a person. But the immunization data that's coming to the CDC is in aggregate, and it's coming from machine connection.
One online question. I see you list CQL there. Could you please explain more?
So this is something that is further afield. So in United, so I said I wasn't going to talk about policy, but let's talk about policy a bit. In the United States, there's a push towards creating DQMs, digital quality measures, where those DQMs can be expressed in CQL. So forward-looking, imagine a world in which instead of having to have a public health submitter compile one of these public health facing quality measures and spend a lot of time and effort on compiling it, what if you could express the quality measure as a query and then CQL query and then query the system and get the data? So in terms of the things under REST query, the things that are nearer term are going to be that individual resources and the bulk data access. The thing that's further afield is going to be the CQL, but it is on our radar because it has the potential If CQL becomes widely adopted, it has the potential to dramatically reduce burden by reducing the number of custom reports that the stilts would have to create, because you can just query and generate the report from their FHIR server with the authority to do so, if you've granted the authority to do so under a DUI. Does that answer your question?
I don't know if it answers the person. It's an online question, but I think the time's up. Thank you very much, Ryan.
Oh, thank you.